What's up, Ninja Nerds? In this video today, we're going to be talking about cholangitis, particularly focusing on primary biliary cholangitis versus primary sclerosing cholangitis, which is a part of our cholestatic liver diseases. And this is also part of our clinical medicine section. I really hope that you guys are liking these videos. I hope they make sense. I hope that they help. And if they do, some of the simple things that you can do to support us is by hitting that like button, commenting down in the comment section, and please subscribe. Also, help to benefit yourself. Go down in the description box below, click the link that goes to our website. We got a lot of cool premium things that I think you guys, if you could become a member, you can gain access to, such as amazing notes, illustrations. Top of that, quiz questions to test your knowledge, and we're developing exam prep courses and much more things that you can find on the website. So go check that out. Let's talk a little bit about the concept of cholangitis. When a patient has cholangitis, we're not talking about acute infectious or ascending cholangitis. We're talking about more in this scenario, the chronic cholestatic liver disease due to chronic inflammation of the biliary ducts. So there's two types, primary biliary and primary sclerosing cholangitis. What's the difference? Well, really when it comes down to a primary biliary cholangitis, it's just going to be intrahepatic duct inflammation. So you only have inflammation of the intrahepatic ducts. Now with that being said, what's really kind of like slightly confusing off the get-go is that this can be present in both of them. So you can have intrahepatic duct inflammation in both primary biliary and primary sclerosing cholangitis. So I'll represent that here by kind of this red lines here. All of this is going to be indicative of some inflammation. I think one of the big differences though when you're talking about primary sclerosing cholangitis is it'll have some of this red stuff here that kind of indicates inflammation. But something else that it has these areas of kind of like narrowing. So we kind of call these like little strictures. There's like some little narrow areas of strictures, but there's also kind of these like large dilated areas. So you're gonna have large dilated areas and strictured areas in combination with some of that kind of inflammation. What's interesting is when you actually if you were to take some of this tissue, the biliary tree, cut it out and look at it under the microscope, they use that term that you guys remember in your USMLE Step 1, your pathology topics, that it's kind of the onion skin kind of appearance, and that's usually due to a lot of that fibrosis. So that's kind of a similarity between the two. What's the difference? The difference is in primary sclerosing cholangitis, this also happens in the extrahepatic ducts. So all these bad boys are also inflamed. But again, just remember, it's not just inflammation, it's also areas that are kind of like strictures due to the chronic fibrosis, that onion skinning kind of appearance, and then again, that beaded appearance, which is kind of like that dilated areas due to kind of like the destruction of the tissue, and again, narrow areas consistent of the fibrosis causing strictures. So with that being said, you have a combination of the two here in primary sclerosing cholangitis. So you have extrahepatic duct inflammation and intrahepatic duct inflammation in primary sclerosing cholangitis, but only intrahepatic duct inflammation in primary biliary cholangitis. Question comes up, what the heck is causing the inflammation of these biliary duct systems? For primary biliary cholangitis, it may be antibody related. So what I mean is there may be these specific little antibodies that 95% of the time, I'd say about 95% of the time, these antibodies are relatively suggestive that a patient's gonna have primary biliary cholangitis. So if you test for these are called your anti-mitochondrial antibodies. And again, 95% of the time whenever you're testing these patients for this antibody, they're usually positive, and that's usually suggestive of primary biliary cholangitis. What these antibodies do is they'll start attacking your own tissue, and when they attack your own tissue, they'll generate an immune reaction. That immune reaction will trigger inflammation of the intrahepatic ducts, and we see this disease. Question comes up, what in the heck is causing these anti-mitochondrial antibodies to be generated? It's pretty straightforward in the sense that these anti-mitochondrial antibodies are usually associated with autoimmune diseases. So if a patient has something like systemic sclerosis, which we can kind of say is scleroderma, if they have something like Hashimoto's thyroiditis, if they have something like rheumatoid arthritis, things of autoimmune nature, they likely will have autoantibodies. And one of those autoantibodies that may be going and attacking the intrahepatic ducts is the anti-mitochondrial antibodies, okay? All right, cool. With primary sclerosing cholangitis, there is antibodies that are related here, but they're not the primary cause. They're just supposed to be some of the causes. They're associated with it, but if you have these, it doesn't necessarily mean that the patient has, for this example, primary sclerosing cholangitis. They definitely have been associated with it though. So some of these antibodies that have been present, there's a bunch of them. You have what's called ANAs, but one of the more specific ones, I think about 80% of the time, 90% of the time that they've been found, is called p-ANCAs. So there's another antibody which is called p-ANCA. These are your anti-neutrophilic cytoplasmic antibodies. And what happens is these antibodies, again, will go, they don't necessarily directly attack the tissue. What these generally do is they activate kind of your immune system cells, like your PMNs, your polymorphonuclear leukocytes, like neutrophils. And these bad boys will go to the actual site of intrahepatic ducts and extrahepatic ducts, and will trigger this inflammation reaction. So they'll stimulate extrahepatic duct inflammation, and they'll stimulate intrahepatic duct inflammation, along with chronic layers of fibrosis, which leads to these strictures and narrowings, as well as beating from destruction of the tissue. Now, the question that comes up is there anything that we can really utilize on the clinical exam that could be associated to help us think, oh, that's PSC or primary sclerosing cholangitis? Oftentimes, primary sclerosing cholangitis, they may have something that could be related to the p-ANCAs, and this is called inflammatory bowel disease. You know, when patients have inflammatory bowel disease, particularly ulcerative colitis phenotype, if they have PSC, there is a 90% chance that they also have UC, but it doesn't necessarily mean the opposite kind of process there. So if they have PSC, there is a 90% chance of ulcerative colitis, but not necessarily that reversible type of process there. So what I think is helpful here is that in the clinical vignette, if the patient has a history of inflammatory bowel disease, and they also have findings that could be suggestive of a cholestatic liver disease, could they have PSC? It's definitely possible, but that's not guaranteed. What we can say is likely guaranteed is if we find that a patient has PSC, we go and we diagnose them with PSC, it's probably 90% likely that if we were to look and see if they had ulcerative colitis, they probably have ulcerative colitis. And that's the relationship that you want to be able to understand from this. Okay, with that being said, we don't have a really nailed down theory of why this process happens, and we have a pathophysiological difference. What's some of the classic findings that I really want you guys to remember with cholestatic liver diseases pertaining to these chronic cholangitises? Well, they cause biliary duct inflammation. And whenever you have this like nasty biliary duct inflammation, what do you kind of see out of this? Well, with inflammation of the biliary ducts comes strictures and narrowing. So you might develop these kind of like strictures and narrowing per se that is actually going to arise in the actual biliary tree. So inflammation eventually over time chronically lead to laying down of fibrous tissue, and this laying down of fibrous tissue will then impede the normal flow of bile. So bile should be leaving. So for example, here's your hepatocytes, they'll make bile. Normally, this should move in this direction. It should move through the actual biliary canaliculi and then eventually out via the biliary ducts. But if for whatever reason you have some type of obstruction along this pathway, in this case, the PBC or the PSC, this will not occur. What happens is all the molecules that are a part of bile will build up. So what will happen is, as a result here, is that you'll develop a buildup in particular bile molecules. You'll develop a buildup of bile salts. You'll develop a buildup of bilirubin. And you'll even develop a buildup of something called alkaline phosphatase, which is kind of like a marker of cholestasis. So all of these can be on the elevated side. But what's the particular finding here? So obviously if I look in the labs and I see an elevated bilirubin and elevated alk phos, I know cholestasis and I can go thinking about these causes. But what is maybe helpful is when a patient has elevated bilirubin, one of the things about bilirubin is it loves to deposit into the skin. And when it deposits into the skin, it deposits into the sclera. And when it deposits into the sclera, it'll cause icterus, right? So it may cause icterus, which is kind of like that yellowish discoloration of the sclera. On top of that, bilirubin also can go and deposit into the skin. And when it deposits into the skin, it can cause yellowish discoloration of the skin. And that yellowish discoloration overall of the skin may be referred to as jaundice. And so you want to watch out for that, because this is definitely, I'd say, one of the more common types of presentations of patients who develop cholestatic liver diseases, especially in the scenario of PBC and PSC. The other thing is bile salts. These are the weird ones, man. When your bile salts are really elevated, right? So there's all these different types of bile salts, urso and deoxycholic acid, all these different things. They can go and deposit themselves, we'll do these in a different color, into the skin. And when it deposits into the skin, it may trigger a mast cell reaction potentially. There's not a guaranteed reason as to why, but what we've noticed is that this can cause a lot of itching. And so pruritus tends to be a super common finding here. And so I think some of the things to look for here is, do I have a patient who's jaundiced appearing? Do I have a patient with significant pruritus? If I do, I should go looking for a cholestatic liver disease. Oftentimes, I'll obtain lab work. Is the bilirubin elevated? Is the alk phos elevated? Definitely supports a cholestatic liver disease. I get a right upper quadrant ultrasound to make sure I rule out an obstruction of the biliary tree. Like, is there choledocholithiasis or ascending cholangitis? And if that's the case, I can say that's the cause. But if that's not the cause, and the patient doesn't look as septic appearing, and this is more chronic, then I can start thinking about, could it be PBC or PSC? And this is usually where really advanced imaging, which we'll talk about in a little bit, like MRCPs and ERCPs, are potentially very beneficial. All right, let's now talk about the complications of these diseases. All right, my friends, so now a patient comes in, they have PSC, they have PBC, they'll present with potentially some jaundice findings, maybe some pruritus. You're like, I don't really know. The jaundice maybe makes me think about cholestasis, especially the bilirubin. I get some labs, I start thinking about, okay, the bilirubin's elevated, the alk phos, definitely cholestatic, okay. And then I'll start running out all my different types of tests, right, to try to figure out, is this PSC, PBC, or something else? I think one of the other things that you should be on the alert for and watching out for as potential complications that could arise within these diseases is something like fat malabsorption, because these are chronic diseases. And so because of that, you're going to have this impedance of bile flow. So that inflammation, yes, the bile may back up into the circulation, but it's not also going into the proper location, which is eventually from the biliary tree into the small intestine, right? And so this process is being inhibited or impeded. This is not going to be moving in the direction that you want. So because of that, there's going to be decreased amounts of bile flow. So here we'll put like decreased bile flow running through this biliary tree, therefore decreased bile present within the GIT as a result, all right? Now, the problem with that is that bile is supposed to bind on to what? Well, the bile salts help to emulsify fat and aid in its absorption. So here's a bunch of fat molecules that I really want to be able to absorb into my bloodstream. So this is some fat globules here. But the bile is supposed to emulsify the fat. Am I going to get that emulsification factor? No. And so is the fat going to be properly absorbed? No. And so what happens is there is a decrease in fat absorption. And if there's a decrease in fat absorption, the problem is all the other things that aren't going to be absorbed with the fat. You know what that is? Fat-soluble vitamins. And so you'll have a decrease in fat absorption. And so patients definitely will lose weight, right? Because they're not going to be absorbing the particular molecules that they need, such as fats, to help them to, utilize that, deposit it into the actual liver, deposit it into the actual adipose tissue, utilize it by the muscles, so they can start to experience some weight loss. But the other thing is that decreased fat absorption also can lead to decreased absorption of nutrients or micronutrients, such as vitamins. So they can have decreases and vitamin A, D, E, and K. So vitamin A, D, E, and K. There could be decreased amount of absorption of these as well. And this can look a variable different ways. So vitamin A is important for the vision, right? So they may develop things like night blindness. Vitamin D is important for calcium absorption, so they could develop kind of like weaker bones, things like osteomalacia, potentially osteoporosis if it's an older individual. E, which is important for also skin development as well as red blood cell control. They can develop hemolytic anemias. K, which is important for blood protein synthesis, so particularly, clotting protein synthesis. And so they may develop decreased clotting proteins, and so they can develop bleeding as a result of a vitamin K deficiency. So it's important to be able to realize that. So if a patient has not just jaundice, pruritus, but they also have features of maybe weight loss, fat-soluble vitamin deficiencies, and here's another one, their stool smells horrific, foul-smelling, and it looks super greasy appearing. This is called steatorrhea. And I think this is something else to watch out for. This is usually these greasy, foul-smelling stools, which is just rich in fat that didn't get absorbed. All right, that's one concept that I want you to understand. The second thing, which is probably the most scary complication that can develop from these, is cirrhosis. Yes, cirrhosis can develop from this. It's definitely not going to be the most common cause, but it can happen. The concept behind this is that there's an increase in bile backflow. Right? So if you have an increase in bile backflow chronically over time, what happens is some of that bile can back up via the biliary tree. And some of these bile molecules, they have the capabilities of, over time, leading to certain reactions that can cause destruction of the hepatocytes. So whenever you have intrahepatic duct inflammation, biliary backflow, this definitely over time will start causing hepatocyte injury. So if you get hepatocellular injury that occurs over and over and over again, this is going to lead to chronic disease that's causing destruction of these cells. And over time, as you have continuous chronic hepatocellular injury, what's this going to lead to? Eventually, this liver cells will have to compensate, and this will eventually lead to fibrosis. So you're going to stimulate fibrosis of the liver. When you increase the fibrosis, which is going to be laying down within the actual liver tissue, what's then going to start to develop? Cirrhosis. And that's the potential complication here. And so then you start leading to decreasing liver function, right? So as the liver function starts to decline, you start noticing, oh, they have decreased albumin. Oh, they have increased bilirubin levels. So they have jaundice. They have decreased ability to metabolize estrogen. They develop hyperestrogenism symptoms like the skin findings, like the spidery angiomas and testicular atrophy and pulmonary erythema. And then they start developing complications related to portal hypertension. So you notice that they have a decline in their liver function, but also they start experiencing things like an increase in their portal pressures. So increasing in portal blood pressure, which is portal hypertension. And this leads to all the scary complications of cirrhosis, which we'll talk about in that video by itself. But it is possible for these two to cause cirrhosis chronically over time. The last one is cholangiocarcinoma. This is a cancer of the actual biliary tree. One thing to note though, is that this is way more common in patients with PSC. PSCs, I'm going to write that down. It's affecting more commonly patients with PSC, not PBC. So PSC, not PBC. Sounds like I'm doing like news channels here, but this is important to be able to remember. Now, when patients have primary sclerosing cholangitis, they develop chronic inflammation, right? So whenever you have increases in inflammation, especially chronically, inflammation is like a nidus for the cells to say, all right, I'm going to start adapting and changing in ways that I shouldn't be. And it may start undergoing dysplasia. So it tries to adapt, but unfortunately that adaptation is not, appropriate in this scenario. Whenever you have increasing dysplasia as a response of chronic inflammation in the setting of PSC, particularly of the extrahepatic ducts, here we'll put extrahepatic duct inflammation. That's why it's more particularly prone to PSC than PBC. you're going to start seeing cancer arise. And so this is where you're going to have a risk of cancer of that biliary tree that is much higher. And that is what we'll start to see, is that we'll start seeing, oh man, this thing is chronically inflamed and inflamed and inflamed over time and over time. Eventually, these cells will start trying to adapt, it'll become dysplastic, and eventually you develop this mass. And this can definitely worsen, a lot of the times, the cholestasis. They can develop more cholestatic mechanisms, and oftentimes you would see this on imaging MRCP. Sometimes you have to do an ERCP to go and really look for this. But that covers the complications. So now the next step is we have a patient with PBC or PSC. How do we go about diagnosing them? All right, so we now have a patient who maybe comes in with jaundice, they come in with some pruritus, maybe they have some concerning signs of cirrhosis, maybe they have some fat malabsorption, some steatorrhea, some vitamin deficiencies, or we're concerned that they have cholangiocarcinoma. Either way, we got to figure out if they have this disease. So do they have that jaundice? Well, if so, you should always get LFTs in a patient who's bearing jaundice to look at their bilirubin, to look at their alkaline phosphatase. If their bilirubin's elevated, their alkaline phosphatase is elevated, and especially if the GGT is elevated, it suggests that it's most likely a cholestatic injury. Now, do remember that in patients who have cholestasis, they can cause a mild elevation of their hepatocellular enzymes, AST and ALT, but it's really these that are the most important. If I see that, it definitely suggests a cholestatic pattern. So then I have to think, I got to go back to my LFT interpretation. In cholestasis, it's either intrahepatic or extrahepatic. And if it's extrahepatic, I know that the right upper quadrant ultrasound will tell me if there is a stone or some type of stricture or something obstructing the extrahepatic ducts, like the common bile duct. So I should really get a right upper quadrant ultrasound, because I know that if it's intrahepatic, then the ductal dilation would be negative, but if it's extrahepatic, the ductal dilation would be positive, meaning that I'll have some type of stricture that's obstructing flow out of the liver and causing the actual bile to build up proximal to that, dilating the common bile duct. If that happens, I then should get an MRCP or an ERCP. The reason why is, if this is positive, I know it's likely PSC. And I'll be able to see this beaded-like appearance. So I'll see areas of stricturing. I'll see areas of like these dilated portions or beaded appearance, which is super suggestive of PSC. And the ERCP, I would be able to see the same thing. It's just this one's a little bit more invasive. If that's the case, and I see areas of strictures and I see the beaded appearance, then I know that this patient definitely has PSC. And I don't really need to go any further. However, if the ductal dilation is not present, then I think that it could be intrahepatic. In this scenario, it's always good to send off like your viral serologies and send off an anti-mitochondrial antibody. The reason why, if the anti-mitochondrial antibody comes back positive, it's really suggestive of PBC. It's about 95% kind of specific. However, it doesn't guarantee that the patient may have PBC. And so the only way to truly confirm would be to obtain a biopsy. But oftentimes, this is usually enough to make the diagnosis. All right, let's move on to the next part here, which is how do we treat patients who have PBC or PSC? So with PBC, there's intrahepatic duct inflammation, and that's it, due to antimitochondrial antibodies. And in this scenario, we need to be able to think about, okay, what can I do in this scenario? You would think, oh, I'm going to give them like steroids. So steroids will shut down because it's autoimmune related. There's actually not a lot of like evidence to suggest that. And so what we really do is we aim more at trying to decrease further injury. And so what we do is we decrease hepatocellular injury, and we do that by giving them something called ursodeoxycholic acid. This has been shown to have an anti-inflammatory effect. It's also been shown that it can help to increase some of the bilirubin production, which helps to improve the effects of the cholestatic process. And so what we see in these patients is that this may help to reduce the risk of them progressing to needing a liver transplant. And so that's very, very helpful. For the pruritus, we have to bind up those bile salts. And so what we do is we give them something called cholestyramine, which really helps to eliminate this process of a lot of the bile salts. Believe it or not, for PSC, it's the exact same thing. You're trying to reduce the risk of them developing massive liver injury and progressing to cirrhosis and needing a liver transplant. So ursodeoxycholic acid has been shown to have that anti-inflammatory effect. And usually in patients who you see When you use ursodeoxycholic acid, if you see that their alkaline phosphatase, you see that their bilirubin levels are starting to decrease over time, it shows that the therapy is actually improving. And if their AST and ALT are also not really trending upwards, they're not developing signs of cirrhosis, it is showing that the patient is responding well to ursodeoxycholic acid. And again, if you're giving them cholestyramine and they're improving, their itching is getting better, it shows the effectiveness of the cholestyramine. One extra thing to add on here is that in PSC, oftentimes these patients can develop pretty bad jaundice. They definitely can develop pretty bad pruritus, and sometimes they even can develop other issues, such as maybe a lot of problems related to increasing the risk of cirrhosis. So in that scenario, there may be a patient who could be a candidate of a stent. And what we would do is we would put this stent in, and it would extend pretty much throughout the entire biliary tree through that common bile duct area. That may open up the area and improve and restore bile flow. And that may help to reduce some of the jaundice, the pruritus, and other associated complications like increased risk of malabsorption, increased risk of cirrhosis, etc. And so that's something that we may do, and sometimes it may even be helpful on a palliative standpoint as well. So again, in both of these, reduce hepatocellular injury, reduce cirrhosis, reduce liver transplant with ursodeoxycholic acid, treat the itching with cholestyramine, and in patients with PSC, especially with really bad jaundice, elevation in their cholestatic pattern, and again, pruritus associated with maybe increasing risk of cirrhosis and malabsorption, you should put in a stent, and that may help to restore bile flow. All right, my friends, that covers the cholangitis lecture. I hope it made sense. I hope that you guys did enjoy it, and as always, until next time.